have a question and answer period, and then by that time, some should be here, and then we'll call on Dan to give us a tour of the current version of Relma. So that's the plan. Okay. So actually, this is long version, but the now LOINC 0.21. I think the numbers are right. There are about 48,000 codes. 35,000 plus of those are lab LOINC codes. About 10,000 are clinical LOINC codes. Then 921 that are associated with chemical claims attachment proposal, and about 1,600 that are survey codes. So we'll talk more about those categories and what's going on there. LOINC is protected by copyright, but it's licensed for use. You can download it directly from the Regan Street LOINC website. There are also list servers. I think there's I know there are list servers that are associated with HL7, but there's another list server now as well. There's a regular thing. There is Relma, which is the Regan Street LOINC mapping assistant that we'll do a demo of a little later, but it's a browser / mapping tool that you can use to investigate and browse the LOINC terminology. So LOINC then covers these 4 areas. There's laboratory LOINC, which are all of the laboratory things, including genetic testing and veterinary medicine testing. There's clinical LOINC, which are all of the things that you can measure, say, directly about patients. Blood pressure, heart rate, KG findings, head circumference, all of that sort of stuff. There are the HIPAA attachment codes, which the content of that is actually managed by the HL7 attachment special interest group. And those are the codes that are specified for use HIPAA attachments. Those are attachments to the claims transaction in X12, and those codes are meant to be used to send clinical data to support and substantiate the claims. And so that's been an ongoing activity for quite some time, and there's special capabilities in Relma to browse those as an implementation of that specific attachment proposal. And then there are survey questions, and one of the most important and largest survey questions that have been implemented so far is the minimum data set, which is the skilled nursing home data set surveys. I'll show a couple of slides about that, but there's a lot known about that. And Tom White has been really leading a lot of the activity there, though that a lot of the work has been done by Dan and by others in Regan Street, by Kathy Mercer and Clemens, actually creating the system. So those are the 4 categories. Starting back and doing sort of some background on LOINC, the use for LOINC really comes from and initiated from the idea of patient data exchange between systems. Primarily, it's been tied to HL7, but in fact, LOINC codes are used by DICOM and can be used by any data exchange standard. Use sort of a name value paradigm for that exchange. So in the messaging paradigm, the idea is that there's something that happens in the real world. A patient visits a hospital or found with a sign or symptom. They register them in a system so that the system is now aware of the patient or aware of this encounter, and an order is placed in the system for a diagnostic test or other kind of thing, and that causes information to flow from an ordering or a clinical information system to, say, a pharmacy system or a laboratory system. They do the work that was requested, and ultimately they send a result back or send an acknowledgement that the work was done. And it doesn't have to be computer systems, where you play. It could be if we're trying to exchange information from an ambulance or from any sort of healthcare environment. So LOINC codes are really kind of envisioned to be used in that environment for data exchange. It also could be information data exchange to public health, data exchange specifically for reporting or other kinds of things. So those are all use cases that were envisioned for the use of LOINC. Just some more detail about how LOINC codes fit into a message. And this is an example of HL7 message, HL7 version 2 message. And we can give examples of how LOINC codes are used in EDA, version 3, Clinical Document Architecture standard. Talk about how they're used in DICOM or how they're used in version 3 message. But this is an example from version 2 of HL7. And so this is a very brief HL7 message. You have each line is essentially a segment within the message. The first line is a message header, and it says what kind of message this is. The second line is the patient identification segment that tells which patient this information is about. And OBR is an observation request segment that says for if this is an order, it's saying what is ordered. If this is a result, it's making the tie this result back to the order that caused this result. And then what you have are a couple of OBX segments on the bottom, and those OBX segments are actually carrying particular clinical findings or measurements about the patient. And each OBX segment has data fields. The data fields are separated by vertical bars, and then a given data field actually can have subfields or components which are separated by the carets or up hat within the message. So that's the general overall sort of strategy for HL7 version 2 message. Are there any questions about sort of the general layout there? No. So, yeah. So in we figure out a way to do it pretty easy, but it's not standard HL7. So you could, if you wanted to do it, you could essentially send some expression of code that's just a text field. So you would just label the OBX as being text and put what you wanted to as a post-coordinated expression into the values. And that would at least get past parsers, but you would have to do something specialized to interpret it, because it wouldn't be standard. There's nothing standard about doing that in version 2. So, what's the real use case for LOINC? And it's all about interoperability, being able to unambiguously exchange information between parties. And so typically what's going on today is that if you have one site, they would have a particular local code. It could be numeric, or it could be alpha, or it could be some combination that represents the item of information, the data element that they're sending. But a second site could have an entirely different number or character string, and a third place can have yet another different one. And the same thing is going on in the actual value. So that first field is saying, what is this data element that I'm talking about? The second one is saying, what's the value for that attribute? And so you could have O or type O or O positive. And people reading this could actually probably surmise, they're familiar with medical content, that these really represent the same thing, just different names for the same thing. But computers wouldn't have any automatic way of knowing that these things are the same thing. So what we're shooting for with LOINC, basically, is that people could still use a local description of what they're sending, but what they would do is send a unique code that represented the item that names the data element, and then they would also send, and could send, unique codes that represent the values for that observation. And so you still have even though you're using standard code, you can make local names and other kinds of representations for those codes. But what we're trying to do is essentially make it so that a computer can understand this information because you're referring to common standard codes, both for the element names, for naming the real world thing that you're talking about, and also for sending the value for that measurement or assessment. We're always trying to then create a universal coding system for clinical observation. To do some more detail about this, if I were, now we're still just looking at a single OBX segment in a message. In that single OBX segment, you're going to have some numeric quantity that you're sending. For example, it's a numeric quantity. So for instance, the actual data that you're sending is a numeric quantity that is 38. You're sending the code to indicate what that 38 refers to. And in this case, there's a LOINC code that identifies that this is the temperature reading. This is the patient's temperature. And this field goes the typical way that coding systems are sent in a message. So you have actually three parts here, and one part I'm not using right now. You have the LOINC code, and then in between here, you can have a description of what the LOINC code means. Then you have these characters that actually indicate that this is a LOINC code. Because in this same place, for instance, it would be possible to send some code or to send some other unique identifier for a data element. So pretty much anywhere in HL7 messages, especially in version 2, you always send sort of the coding system that coded from in the code, an option will send text with that item. So that's a LOINC code that in this case is saying this is the temperature reading on this patient. The actual temperature reading is 38. The OBX can be used to send numeric data or coded data or a date and time or a string or a paragraph of information. And that's indicated in that where this is in that second part of the OBX segment, where the NM is just indicating that the data value is going to be numeric. And then you also have, for something that's a physical quantity, you have associated units of measure. And so this is basically, P is representing a code that's maintained in an HL7 table that says this is a centigrade measurement, units of measure. Then you have some other things in here that I didn't fill in that just, say for instance, this is final status for this item. And so that's the typical way that LOINC codes fit into an OBX segment. Questions about that? Okay. Second example is now, rather than showing a numeric quantity, we'll show a textual item or a coded item that's sent. So in this case, in the OBX segment, it's indicating that the CE indicates that this is a coded element. So the data now, the actual value for this observation is going to be a coded element. Again, we have a LOINC code that identifies that this is an ABO blood group. Again, we have the LN that indicates this is coming from the snowman, or excuse me, LOINC coding system. And then you have the actual value that in this case indicates that the patient's blood group is hypo, and in this case that code is coming from SNOMED CT. So what happened?
I think the sharing just died.
No? Sharing just died.
I can still see him.
I can still see it.
Okay, good.
I can too.
All right. So I don't know where that came from, but we'll just continue it. So
Just rejoined it.
this is the typical way, again, that the LOINC code would be used in association with the coded value for what you might think of as sexual data that was being sent. And so this is important not just to show how the OBX segment works with LOINC, but it also shows the potential division of labor between what you normally find in the LOINC file and what you find where there are some internal codes for these things within LOINC. But LOINC is trying very hard not to include a list of diagnoses or to include a list of signs or symptoms or body parts or any of that stuff as part of LOINC. Those are all things that we're looking for SNOMED to create and use those values from SNOMED. Whereas over in this space, LOINC wants to be comprehensive and make concept identifiers for everything that could be or should be set up. So that's illustrating sort of that potential division of labor between LOINC and SNOMED in this example. Questions about that or comments?
And what was the reasoning behind deciding to only the groupings and not the actual data?
It already existed, and so there wasn't an interest to be doing that work. There were no codes essentially over there, and even though there's overlap with SNOMED is less than 5% in that area. So there was no terminology that we knew about that had these kind of observation identifiers, and so we focused our efforts there and intentionally didn't make the values because those already existed in SNOMED. A lot of work had already gone into that. So it was really, we were basically trying to work where we could do the most good and reuse what had already been done by other groups.
Stan, this is Sundak. In the public health, we have in most of the forms, we have questions as a kind of symptoms, like do you have nausea, do you have vomiting, do you have fever? So those kind of things are still kind of considered as a question, but typically normally, like as you have explained, normally the question you would expect it to be a sign and symptom, and the value to be one of the values is coming from a sign and symptom domain from SNOMED. So would the LOINC committee would encourage or would support these kind of questions that we see in the public health questionnaires?
So with this thing here, what you would do is use one code that says this was an assertion of, about something, and then carry the data as the value rather than carrying it as a yes/no question in the LOINC terminology. Now, the thing is, you can ask the question as a yes/no question, the checkbox, and then have the application convert it to a name-value pair that is of the general form. So you can still have your form look the way you want it and not cause the propagation of all those LOINC codes. that correspond one-to-one to a yes/no question. And we can talk more about that, if you want to, at some point. But
as a follow-up for that, Stan, is there a LOINC code that says yes, I am an assertion?
There's probably not one that's that general, but we could make one. Normally, it says something like, past medical history or diagnosis or something. It has some very general label, but it's not as general as just assertion. But we could make one for assertion, which would correspond to the term info. I'm thinking about this.
Thank you, Stan.
Yeah. Other questions or discussion? Okay. So, again, our focus is on creating the value for observation identifier. We focused on making the names of individual results first. So that was for the first few years of LOINC creation. But then we started creating panels, and so there are a lot of panels that have now been created. The individual result names can be used as the result, or it can be used as the ordering name. So you get kind of full meaning by knowing that this code is inside of, it's the thing inside of an order, or it's the thing inside of a result record. So we use the same codes as ordinal codes and as result codes. The LOINC codes are intended to be used to create a unique meaning for the data element that is being sent. And so the names, and we focused on making the unique characteristics of the item more so than creating user-friendly names. And the real assumption is right now that people will, within their own electronic medical record system, make user-friendly names for these things. So some people look at LOINC and say, boy, those are ugly names. We say, yeah. We know they're ugly. In a sense, they weren't intended to be the most user-friendly. And one of the things that we have talked about, is that there's nothing, though, that would prevent anybody from basically making a file that would show nice user-friendly names that everybody agrees to for these items. And it's work that we haven't done yet. There are short names for LOINC codes that unique short names for all of the lab LOINC. There are short names for some of the clinical LOINC codes, but not all. And one of the agenda items today is, or sometime today or tomorrow, to talk about whether we ought to systematically make short names for all of the clinical LOINC things. So that's stuff that's going on. So the ideal situation is that there's one common identifier, one common LOINC identifier for all tests that are really the same test clinically. And there's a little bit of fuzziness around that, but what it means is something that can be used in identically the same way for patient decision making or for tracking the patient could have in fact one LOINC code. This all started with Clem back in '94. Regan Street has been supporting this work for a long time. The National Library of Medicine supported the LOINC work through grant contracts for a long time. And we began creating clinical observations in 1996. The approach, ideally, to how we make LOINC codes is gather codes from people who are actually already using the information in the electronic medical record system or in a clinical information system of some kind. So, for instance, when we started back in '94, we gathered things up from Intermountain, from the VA, from Regan Street, Mayo Clinic, from 3M and their customers, from a bunch of the commercial laboratories, and said, basically got their test libraries and said, these are things that people are really using. We looked at that information, formulated a model, and said, okay, in this information, it looks like there's the name of something you're measuring. There's a fluid that's measured in. There are things that indicate whether this is a measurement at a single point in time, or it's a measurement that ends up being an average over some period of time. And we formulated a model and said, based on the things that we're seeing in people's names, these are the characteristics or attributes that we can combine to make unique names for these items. So we create these fully specified names, and we'll talk more about them. And then what you do, though, is that you sort of apply those, apply that model to the actual codes and make unique names for all of them. And then do some evaluation and say, are there anything that is really two different things that ended up with the same name? That would be bad. And the other thing is if there's something that was the same thing that ended up with two names, that would be bad. So you sort of adjust the model until you don't have that circumstance existing anymore, and then you say, we're good. And so that's sort of what we do. We did that with the lab domain. We did that with radiology. Depending on the domain you're in, it's sort of easier or harder. We're doing the same sort of thing right now with a lot of genetic testing and trying to understand genetic testing. That's going on in the LOINC area. But that's the general strategy for how we create LOINC codes. And it actually works the best if there are multiple systems that have been actually using codes to represent their data, because then you have real users who are doing it. Sometimes we get into situations where we're making things that people aren't using yet, and we're sort of projecting into the future, and we make some missteps because when people get really doing it, it turns out different than how they thought it would be when they were just planning to do it. So it really works the best if you have a lot of people who are already sending a particular kind of data around. Any questions about that? So, needless to say, we don't sort of just make everything that could possibly be made then. What we do is actually make names for things that people are using and that represent real clinical entities. We do make names that allow both atomic or post-coordinated use of the code and molecular code. So, as an example, we would make a code that said systolic blood pressure. We would also make a code that said body location of blood pressure measurement. And you could use those two codes in combination to represent that this was a systolic blood pressure from the patient's right arm. We would also have, associated with blood pressure, we can have the patient's position, say that the patient was in a sitting position or a supine position or that sort of thing. And you can use the primary blood pressure code with two other codes, one that says the location of the measurement and the patient's position at the time of the measurement. But we would also have, in fact do have SNOMED codes that say systolic blood pressure right arm. So it's all combined into one code.
Stan? Stan? I think somebody may have enabled their desktop instead of yours, so could you please re-enable just on the left top corner, re-enable your desktop sharing? Yeah, we can see now. Thank you, Stan.
A lot of the early LOINC thinking actually was a collaboration with folks from Europe. How many of you here were there in those days? I don't think anybody here was back in those days, but worked with Henrik Olsen, who wrote the Silver Book, which is a Canadian book that describes measurements and really talked about components, systems, and kind of properties. It's a very elegant treatise on that information. And George Demore and Tom Fears had a system called Euclides that actually had a 32-axis description of laboratory things that talked about the specimen type, specimen preparation, gender of the person that the test was done on, how the test was sampled, what was measured, kind of instrument that was used to measure it, all that sort of stuff. And we learned a lot from that, and you recognize, for instance, that the component system kind of property has prevailed in a fundamental tenet of how LOINC codes are created. We'll talk more about what each of those things is, but just to recognize that there were a lot of people who the conceptual framework. Just organizationally, there are two separate branches of LOINC. There's laboratory LOINC, clinical LOINC committee. Clem is the father of everything. He manages the laboratory LOINC meeting, and I manage a clinical LOINC meeting. The next lab LOINC meeting is in December. So if you're interested in lab LOINC, I would encourage you to come to that meeting. This is just an idea of some of the people who've been principal. Some of these people are no longer active that had roles early on, and a lot of the lab LOINC codes in this set of people. Again, some may not be active still, but very active in creating clinical LOINC codes. Lab LOINC covers all of the usual kinds of things in the laboratory, like chemistry, urinalysis, blood banking, hematology, microbiology, molecular genetics, all of those kind of activities. And clinical LOINC are all of the things that you can measure on patients or images taken from patients, vital signs, hemodynamics, cardiac output, INO, emergency department findings, standard survey instruments, document names. All of those things are part of clinical LOINC. As Huff has pointed out, laboratory LOINC is fairly self-defined or focused. Clinical LOINC, though we haven't created as many codes yet, clinical LOINC is essentially everything else that you want to say about a patient that isn't laboratory. So in essence, the universe is bigger for clinical LOINC than lab LOINC, but we haven't populated as much of that universe yet. Codes. Those are the subject areas. Now, just so everybody knows, this is the LOINC mascot. This was discovered programmer Jill Vogel. Yeah. She painted this on a T-shirt. as kind of a joint one time, but it's sort of my favorite LOINC mascot slide. Pig with a beret and a little attitude there. All right. So we're going to go on then and talk more specifically about clinical LOINC structure and content. But any questions sort of on background and organization and questions? Going to that next section. Okay. So through sort of that trial and error process of creating models, we found out that there are 6 things that almost always come into play. When you get into document types and collections, these things don't apply as much. But anything that sort of is a measurement, there are these 6 things that typically apply. There's a component, there's a property, time, system, scale, and those things all taken together end up making a LOINC code. And we'll go into further examples of this. But the example that we're looking at now, for instance, LOINC code 8331-1, the component is the body temperature. The thing that you're measuring about body temperature is the temperature, so that's a little bit redundant in this case. The point in time measurement, so this isn't an average measurement over time, but it's just a point measurement, and measured by mouth, quantitative measurement. In general, the first 5 parts are mandatory, so the parts that are in blue on this slide are things that have to be defined, because if you don't define those first 5 parts, you don't end up with the unique definition for the item. And then method can be included when method is important. And method is important basically if it creates different sensitivity or specificity around the test that's important for clinicians to understand. So sort of the idea of the method tells me whether this is a screening test or whether it's the final confirmatory test kind of thing, then the method becomes important. Otherwise, we try to not specify the method or have that be specified in another part of the message rather than make LOINC codes that would change rapidly because particular methodology is changing. Any questions about that? Okay. So the kind of things that each of those axes represent are, for instance, in the component, representing something like the ejection fraction, heartbeats, number of breaths, a circumference of something, an angle, excuse me, not an angle, but that could be basically some aspect of the patient that you're measuring or evaluating. And the kind of property says, whether the thing is actually just a count of something or whether it's an angle or an area or a length or a mass. The kind of property is, when you get into things, it helps you to know whether you're measuring, for instance, the pulse, whether you're measuring the number of times that you have a heartbeat per second, or whether you're measuring, or whether you're talking about whether it's the rhythm of the heartbeat, or the intensity of the heartbeat, whether it's bounding or some other characteristic. So that's what kind of property helps you distinguish clinical LOINC items. And then timing, again, is whether this is something that you evaluate at a point in time and you have an individual value at that point in time, or whether it's something that could be measured over a shift, or something that was the first one that happened when they came to the emergency room or during an encounter. Timing is expressing the temporal duration of the measurement or its association to some other clinical event. The system is further specifying something about how the component was measured, whether it was measuring the leg or whether it was measuring some chamber of the heart or pressure in the heart, or it was a particular EKG lead, that sort of stuff. And scale really gets close to saying what's the data type for this element. Is it a numeric data type? Is it an ordinal data type? Can I put it, if it's a 1+, 2+, 3+, or the answer is mild, moderate, severe, I can put them in order, but it's not a scalar representation of that item. And then you have the method again that we talked about, which for clinical items, it might be that the methodology has to do with whether this was something that the patient told you, whether it's something you observed about the patient, whether you estimated it, or you used an ultrasound machine to do it, or a barometer to do it, that sort of stuff. So those are sort of the overview of the components. More examples, basically components, an RR interval, you can measure an RR interval, an orifice, an ejection fraction, number of heartbeats, number of breaths. Those are all components. You can do subtypes of the component where you're talking about a forced vital capacity as opposed to just a vital capacity. Or you can talk about the verbal Glasgow coma score. Or you can talk about the R-wave amplitude in lead 2. Or you can talk about the ST segment axis in the horizontal plane. So if we have some further information that specifies the measurement to a very focused area, you can use a period separator to add in that additional detailed information with that item. You can also have challenges or preconditions around these measurements. So you can have, for instance, urine output, and in that case we're using an up hat or a caret to limit this part, to say that this is the urine output after post-void. So it's a post-void urine measurement, or it's fractional collapse on inspiration, where it's the number of breaths at maximal voluntary ventilation, where it's gas flow in for respiratory therapy charting, but it's the pre-treatment or pre-therapy gas flow, post-therapy, and all that sort of stuff. So there's a fair amount of detail that you can put in here if you need to distinguish important sub-variations of vital capacities or heartbeat or anything. You can also do another thing which is even less common, and that is you can adjust or normalize data to be, for instance, diffusion capacity that's adjusted for the hemoglobin concentration of the patient, where you can adjust it to other body conditions, whether the patient's exercising or not exercising. So adjustments are separated as a second delimited part of the components. Any questions about that? Okay. The kind of property, again, it could be as simple as just saying the type of thing, or you could say whether a given thing is present or absent. You could say this measurement represents a time or a duration, amount of time. It could be a color, an angle, an area, a length, a mass, amount of mass per unit time, pressure, a temperature. Those are all kinds of things that are expressed as a kind of property about this item. Timing can be a point in time, which is the most common by far. You can have the minimum or maximum in a given time range that could be important. It could be that you want the average measurement over a 24-hour shift or over an 8-hour shift. It could be the mean, any of those things. So these things don't come into play that often, but when they do, very important, for instance, to distinguish a point measurement from the average over time, or the sum for a 24-hour period or for a nursing measurement during the nursing shift. So that's timing. System, again, is specifying typically the body anatomy or some other special part about the measurement. Say that this was a measurement that was a pressure in the tricuspid valve, or it was a pressure around the aortic valve, or it was pressure in the left ventricle, all of that sort of stuff. The system is also used, for instance, LOINC codes can be used to transmit settings or readings from an instrument. And in that case, the system specifies that this is setting on the ventilator, where it's set, as opposed to So it could be the number of breaths per minute that is the setting on the ventilator as opposed to the number of breaths per minute that the patient is actually experiencing. So the system is expressing that sort of dimension of the description. Another part of the PARTA system is whether this is a measurement that's being made on the patient themselves or whether it's a measurement that's being made on somebody that's associated with the patient, like fetus or a child, or a blood unit that's being transferred to the patient, transfused to the patient, or a measurement on a donor that might have donated an organ to this patient or something like that. So that's another part of the system, is whether for the patient that we're measuring this on, or is it another person, the fetus, the donor, that we're making this measurement on. The one caveat there is that actually if you're not careful, this can lead to combinatorial explosion, because essentially, especially when you get into a donor or a baby, you can theoretically measure anything in a donor that you can normally measure on a patient. So if you make LOINC codes for all the things that you can measure on a donor, you're going to essentially double the number of LOINC codes. So probably the stronger and more flexible way to represent this data is to do it as a post-coordination messaging, where you would say what you measured, and then as a second field in the message, you would say who it was measured on. That's not always true. It's sometimes handy to just combine it into a single measurement. But yeah.
I can't hear the question.
You got to speak louder. The guys on the phone can't hear you, clap. So Clem was just saying that, if you do the post-coordination, the thing, you have to be careful, because it's easy to mix it up in your system now. And somebody, if somebody who is counting or maybe looking for the blood type of the patient would mistakenly think the blood type of the fetus was the patient's blood type. So that's, if you're doing post-coordination, that's an easier error to make. That's one of the trade-offs.
It does seem important that there be a consistent philosophy about whether to add new codes or assume there's something else that modifies it.
Follow what people are actually doing in their system. So even though potentially you could measure anything that in a donor that's measured on a patient, in actual practice there are a smaller number, and so what we do is we sort of, we make the codes that people are really using, and so it's really an empiric strategy to me rather than some practices dependent, derived from a first principle or something. A given system, LOINC is sort of promiscuous in allowing and creating codes that people are actually using. If you're doing your own EMR, or if you're CDC or somebody else, you would probably be very much in your favor to make a policy about what you're going to do within your organization or what you're going to do within public health. That would be great, but LOINC is probably going to stay agnostic and make whatever people are really using.
I do have another question, which is, if I am trying to propose a new code for clinical LOINC, I need to use these existing components, the system, the measurement type, and so forth. What if I wanted to add some new kind of system or component or timing?
And just put that
reasonable to me. How would I do that?
You just put that into your submission, and we'll add that as a new type.
Okay. So if I want some new type, I just use it, and then if I can get you guys to approve it.
But yeah, you would just in submitting new things, you use the timings and systems and components that exist, but if you need, oftentimes the component itself will be unique because that's the thing that's actually new. But we also have occasions where we need a new kind of timing, or we need a new system, or we need a new method, or something like that. So you just submit those, and we might call and ask you a question about it, but we would just add those, and so the possible values for each of those axes is slowly growing over time. Yeah. Someone wants to make another comment.
Yeah, close. A lot of times, it's just best to say what you need. Let us, either Intermountain or here, work out the final details. You can't always do these constructively when it's new subject matter. And the challenge, the biggest challenge is when it's data that is for the future, not something that's actually in use, because the future always changes. And you're doing some new things. You create, and you have an area of bigger challenge.
Yeah, that makes sense, and I'll try to keep that in mind.
Stan?
Yes.
I have a question here. In public health, sometimes we have, in order to avoid the post-coordination and numerous explosions in the pre-coordination concepts, we have things like subject or case or patient's household. So in those kind of situations, can we use a generic code with the system as XXX or just kind of a curly brace as subject?
Yes, that's exactly what you would do. So, that's what I meant by saying you can do a post-coordinated approach, or you can do a pre-coordinated approach. So if you're doing the post-coordinated approach, that's exactly, you would have another field in the message that says subject, and that subject could be patient, or it could be, it could be a flock, or it could be, a group of people, or whatever, a cohort in a study, and you could specify that in a separate field, and then just have the measurement that you were measuring for that person or group.
But when you say case, is that a patient, a person?
Oh, yes, but sometimes in public health, sometimes the case could be an animal too.
Okay, scale, I don't think scale has changed much over the last long time, but basically it says, it's really saying what is the data type of this element. It can be quantitative, which is, a number or a titer, or it could be ordinal, where you can put things in order, but you couldn't really say that moderate is twice as much as a mild, or say that a severe is 3 times as bad as a moderate. So you can always put them in order, but you don't know what how mathematically they relate. And then nominal is maybe just saying that what you have is an answer, and there's no ordering of those items. So you're just saying something like stool appearance, or you're saying chest tube type, or you're saying like skin color, where you just have a set of colors, and you can't, it's not reasonable to say that pink is greater than gray or something. And then there is an answer is a paragraph of text, or just so there's not really a code associated with the side of it, just a free text and description. So those are the set of scales that are kind of available. Method again is saying that the technique or procedure by which some measurement was made. For clinical LOINC, it comes into play to know whether this was something that the patient said to you, whether it was stated, whether it was something that was measured directly on the patient, whether it was calculated, whether it was estimated, or to be more specific about it being an EKG machine or a scale used for breathing or spirometer, all of those kind of things. So it's specifying something about the procedure, and again, only use it when it makes an important distinction. So, in the laboratory, the example would be that you can measure serum sodiums a lot of different ways, by ion-sensitive electrode, or flame photometry, or by enzymatic methods. Most of those are irrelevant because the sodium is calibrated against known standards, and so the measurement is really kind of unimportant how you measure it. So for the most part, you ignore it, but it can become important, for instance, with enzymes, measurement of enzymes. If you do the analysis of room temperature or at body temperature, you get fairly dramatic differences in the activity of the enzyme. So the methodology becomes important in interpreting particular. And that can be true, with obviously with weights. It may make a difference whether you were guessing that patients weighed this much or whether you actually weighed them at an exact weight from the scale. So the kind of codes you end up with then are just represented here. You have body height, the property is length at a point in time on the patient. The scale is quantitative. You have other things similar, body surface area for the patient. It could be derived in this case. In other words, didn't directly measure the body surface area, but I calculated it based on weight and height on the normogram. Body temperature by mouth. This is a good place to explain about XXX. So XXX is a value that we put into one of the LOINC axes when the intention is to use this code either without further specification or in conjunction with another post-coordinated axis. So for instance, there are two body temperatures here. And the first one that we had, the body temperature is being specified as being taken in the mouth or an oral temperature. But I may want to take temperatures where, in fact, I don't say where I measured it. I don't say whether it was oral or axillary or whether it was in ear with an infrared thermometer. And so I could either use this code with the XXX in it. The XXX is put in the position of the system, and XXX means that either I'm not going to specify where this was done, or I could use this code with the XXX in it, and in the message I could have a different code that was used with post-coordination to say that where the body temperature was measured. So in the post-coordinated mechanism, I would use the primary code, and then I would have another code that said body temperature location, and I would use that second coding as a second OBX segment in the HL7 message to send that information along. And so basically the things with XXX in it, that you can use them alone or you can use them in a post-coordinated fashion with other codes. And so that's what the XXX does. Now, XXX itself, we had a second strategy for that, and you'll see this example in some of the later examples, and that is what we decided to do is actually put in curly braces the name of what it was that should fill in the XXX. So it would say in here, for instance, it would say, body temperature location, and it would put it in curly braces because that part of this expression would be expressed in a different field, or that is missing from the expression of the system in this particular item. So that's, if you see the XXX is in the file, that's what the XXX is meaning. And the newer way of doing XXX has a curly brace, and I'll show you some examples of those also. Any questions about that?
Stan?
Yeah.
Can XXX be used in other axes, like in time?
Yes, it can be used in most any of the other axes. It probably wouldn't use XXX in the quantitative thing. You can use XXX also as a subpart of a measurement. So like in the component where you were doing a challenge or something else, you could use XXX because the challenge part of this measurement was being expressed in another field. But you probably couldn't use it. I don't think you could use it in temperature, and I don't think you could use it in scale. But you could use it as part of component, as part of system, theoretically as part of timing or a subpart of timing.
Thank you, Stan.
More complex examples. These are showing basically some patient conditions or patient preconditions for the measurement. So neonatal Apgar, 2 minutes post-birth, a fluid output, which is the volume rate per 24 hours, the gestational age, where you're specifying that it was gestational age estimated by ultrasound, but not only by ultrasound, but by the Hadlock procedure that was published in 1984. And intratracheal systolic pressure, but it's the pressure that was in the specific heart ventricular outflow tract. And a head circumference that's not just any circumference, but it's actually the maximum circumference of the right, in this case not a head circumference, but a calf measurement. So those are sort of the examples then of sort of the structure and content of LOINC. Any questions about that area before we go on to some other examples? Okay. So we'll talk about radiology. One of the rich areas of clinical LOINC are the radiology codes. And early on, Dean Bidgood, Pat Wilson, Jeff Sweeko, Clam were the ones that really focused on creating the model and the representation for this. And the original collection had hospitals from Indianapolis, a large variety of codes that came from 3M's customer base, and then things that Dean Bidgood knew as a radiologist at Duke University. But the codes came in originally, you just had a big variety of how things came in. So, it could say abdomen, L cube X-ray, or LD cube abdomen, which is really kind of a synonym. Say chest PA and lateral, oblique X-ray, or it could say PA lateral and oblique chest. So you had a lot of variety. And Dean went as far as making sort of almost a pseudo-BNF representation for how the different parts could be combined to make the radiology names. And I think this now is probably mostly in the head of Pat and Dan and others who make these names, because they're very stylistic, and once you've made a particular kind of name for a particular circumstance, and you try and follow that pattern for the rest of the items. But the radiology names then end up looking like left lateral, and the things that are sort of dash delimited have unique meaning. L always means left, and lat always means lateral, and you have the cubitus and Q, and XR is for X-ray, and so you have PA and lateral and right or left oblique. There's a lot of sophistication in these about whether you're doing right and left, or whether you're doing with or without contrast, and a bunch of stuff like that. Also got mixed in there whether it's portable or not portable. Because again, that's almost like method in the sense that it changes the interpretation of this thing based on the fact that whether there's just some things that you can do with it standing against the film that you can't do with a line semi-recumbent in bed, that sort of stuff. So,
is there a way in LOINC to do the film that's taken out? Because that's important too.
So if everybody didn't hear, the question from Mike was, is there a way to know something about the distance? Have we ever done that?
Actually, the magnification is good. Because magnification, under standard terms, I mean, if it's portable, it's probably, if it's skinny, that's probably good. Which is why we make the differentiation between sets that are portable and not. Most everything else is at 40 inches, with the exception of mag. Mag's the list. Yeah. So if by definition, by the fact that it's magnification, if there's any that are different than that, we could probably put that in. I mean, portable,
there are
taking a couple of inches, it's not enough to.
It sounds like if there's some standard differences, then creating magnification terms would be okay. If you really wanted to know, Mike, I would suggest probably you would, if you wanted, if it's varying a lot, then I would suggest that you do that as post-coordination, where you just have it, you include with the item that for that particular measurement.
Well, when we first started, our discussion was that it would determine if it was portable if it changed the view, such as a chest X-ray portable versus a chest X-ray scanning, because the distance is always different. The fluid levels will almost always be different. They can somewhat become a But other than that, we add that. I don't think there are a lot of magnets. But I don't think well, yeah. First, I was just pointing out portable usually have magnets. That was the intent. It said only if it changed the what would come out to determine if it was a portable or not. Like a portable hand versus a regular hand taken in an X-ray room would not be different because we get 40 inches farther.
Mike, do you have any further questions?
No, thanks.
So this is just some more, examples. I was going to go through all these: the left lateral decubus, right lateral decubus, multi-section. When you get into CT scans, a multi-section with contrast, portable views, upright versus lordotic. All those kind of things come into play. So there's a fair amount of sophistication and complexity in representation of the radiology. Okay, we're going to go on and talk about documents. Any other questions about radiology?
Was that we tried to describe it, but mentioned in the LOINC guide, there is a formal that you can go through for everything.
Okay. You get hit by a train and we have to have somebody else run that stuff. Okay, documents. I'm a little behind schedule, but we're actually these last things are getting shorter, so hold with me for a little while. The document naming has been a key activity with the LOINC committee for some time, and there were an HL7 document ontology task force that met the very first time up in Vancouver, British Columbia. Bob Dolan, Pablo Frazier, Clem, Calvin, Leora Altschuler were all involved in creating the model, and the model is used for the creation of document names and codes in LOINC. Document codes are created to provide consistent semantic for documents that are, when they're shared or exchanged across institutions. And so, again, if you're familiar with HL7, the kind of document names and codes that we're making are meant specifically to be used in CDA communication, and it can be used anywhere else. It can be used in version 2 messaging as well, where you're sending a particular kind of document, but it's meant to be used as the document type code in the CDA standard.
Chan,
Yes.
if I were interested in having codes for items that I was collecting on a particular kind of questionnaire, let's say it was, hepatitis surveillance questionnaire, would I want to have a document type code for that concept of my type of questionnaire?
We can talk about that more. The answer is probably not. What you would do is actually make the survey question as a discrete LOINC code, and that's one of the things that we're going to talk about here in a minute. Our survey questions, which is they're their own thing. They have specific characteristics and attributes that make them kind of a unique animal within LOINC. And so for survey questions, you would make them as survey questions as opposed to documents. And the difference, the main difference is that what the idea of the document is that it is either a collection of information or it's a collection of, it's always a collection of information, and so it's not a single discrete answer to a single thing, but it is the things that are documents, are assumed to contain sentences, or that they contain otherwise undefined collections of information. So you can really think of documents as either being, what you would normally think of as what you would see as a printed piece of paper, or an XML CDA thing, or a section within a typical report. And for survey questions, even if the survey question's answer is a sentence, it's usually focused on a specific thing, and so that would be done as a survey question rather than as a document name.
No, I guess what I'm asking about is, let's say I have some collection of those survey questions.
Then it would become a panel.
Okay, so it's a document. Sounds to me awfully like a panel. What's the difference?
Yeah, and I'm going to talk about that, and then you can ask more questions after I show a couple of slides.
Okay, sorry to get ahead.
Oh, that's okay. So the way documents are created, basically, it's a multi-actual approach to creating the document names. As you say, the document type, the type of service, the setting, the subject matter domain, and the role of the author. And we're going to talk about, documents are on the agenda for this afternoon at 3 o'clock, but document type is whether this is a clinical note, it's a letter, it's a consent, it's a reference document, that sort of thing. Something that changes completely sort of the context of this thing. The type of service has to do with whether you evaluated something, you managed something, you performed a consultation or an education. The setting says whether it was done in a hospital, in a clinic, in a nursing home, in an emergency room. The subject matter has to do with whether it has to do with the cardiology system, endocrinology, pathology, and then the role of the author, whether the person who's authoring this document or did author this document is a nurse or a social worker, a physician, an attending, etc.
Can you talk a little bit more about the type of service? So if it's an education type of service, it means I was educating the person when I collected the information on it?
It's information, it was information about an educational session. So this could be a document that said this is a document that describes birth control counseling session, and that would be an educational session. Well, that would actually be counseling in that case, but it could be diabetic education. And so the document is describing the fact that I taught you how to, drop your insulin and give your own injection. And there's an explicit list of the kinds of services which is rather long, because it could be a very specific focus kind of service, like a compensation and pension exam. We have a number of those that are very specific that came from the VA as kinds of services that are provided, or it could be very general, like just essentially evaluation and management, or it could be a physical exam. It could be, but it's sort of the, if you will, it's sort of the action or thing that you perform for a person, and that's independent of the particular subject that you might have educated them about, or the particular thing that you might have evaluated. Now, for those of you who haven't participated in this document stuff, I mean, this has clearly been an empiric science. And there's a lot of judgment that has gone into this, because on the one hand, you want to create names that are at the level that people can use and that provide value in information exchange. But they have to have a precise enough meaning so that if I send you a discharge summary and I use that code, you have some expectation that what you think of as a discharge summary is the same thing I think of as a discharge summary. At the other end of the spectrum, you could make document names that were very specific down to saying this was Intermountain's Tuesday afternoon pain clinic, and that then starts becoming it's very precise and probably usable for Intermountain. But when I transferred that to somebody else, they would, at a minimum, want to know actually that this thing had to do with the pain clinic, because they wouldn't know anything about the fact that it was Intermountain, or wouldn't know what to do with the semantic part of that referred to Intermountain or to Tuesday afternoon for that matter. So these things that we're conjecturing here are things that are things that we found to occur again and again and again, but they may not be sufficient for everything that I want to express. And so this has been an ongoing, slowly growing set of things that we can use to describe document types, and we'll talk more about that this afternoon. But other questions about that? Okay. Things that we try never to put into a document name are the name of the specific author, Dr. Jones or Clem McDonald, the specific location like Intermountain Healthcare or the outpatient clinic, the Herefordshire outpatient clinic place, the date that something was done, the status of the document, whether this is an unsigned or signed document, security flags, whether it's protected or not protected, and whether this is an addendum or an update. We don't put those things there because we assume that they're always going to be sent somewhere else in the document, somewhere else in the message that's associated with the document. So these things are obviously important, but the assumption is that if they are important, that you will send them in a different field in the message rather than incorporating them as part of the name for the document type. Okay. Any questions about that? Okay. Document type code should only express the meaning in the document name that can be shared between. So we're trying to make names again that allow you to share information between different things. And so again, if you started out with a local document name like Dr. Smith's Tuesday Pain Clinic note, the kind of name that LOINC would create for that would be an outpatient clinic note, outpatient pain clinic note, basically. So you're taking away all of those things like Dr. Smith and Tuesday afternoon, and all of those things that are very specific to a single individual institution, trying to come down to the set of things that you think people would understand and be able to share across enterprises with these kinds of names. The name should imply the kind of content that you expect. What we don't do, and again, this is something that we've had a lot of discussion over. We don't make LOINC codes that distinguish whether the document is text, whether it's scanned, whether it's XML formatted, whether it's Word formatted, a JPEG, etc. The LOINC is naming things based on the information content that's expected in the document, and then you would have, again, other parts in the message that would tell you whether this was a PDF file, whether it was free text, whether it was JPEG, whether it was XML with markup. We expect that to be known by some other part of the message. It would essentially say, what is the format type of this particular item? Okay. So, any questions about that? The expectation is that people will have needs for local document names that are more specific than the LOINC codes that are created for the document name. And those codes can be carried in the message, and especially in HL7 messages, there's a second part of the note, or excuse me, there's an alternative coding for a given item, and you can send both the local code as well as the local description for that item as the alternative code in the HL7 coded data element data type. So we expect people to have local codes, and there's a nice way that you can send local codes in messages if that's important. So some of the clinical document names then are just consultation notes, surgical op note, procedure note, initial evaluation note, subsequent visit evaluation note. And you're seeing in this example, for instance, the use now of the curly braces instead of the XXX. So here, for instance, that consultation note is saying this code is one that is a consultation note, and that if it's important for you to know whether it's an inpatient or outpatient consultation, you would set the setting as a separate pre-coordinated part in the message. And if it was important to you to know whether this was a physician consultation or a nurse consultation, or maybe it's even a chaplain or somebody, you would send that as a separate part. You can see, for instance, down here that the fourth item is actually said, no, this is an initial evaluation by a physician, and the fifth item is a subsequent visit by a nurse practitioner. And so you can specify those parts when you want to an exact value to be the attending physician, the nurse practitioner, or you can use the more general code and do a coordinated strategy where you're going to send the role of the person who did this as a separate item in the message. Okay. That's all I'm going to say about documents. Any questions about that? Okay. Assessment instruments. We have a number of assessment instruments like APGAR scores and Brayton scale and other things that are part of LOINC, and you have sort of three categories of codes that are associated with this theme. For instance, with APGARs, you have individual codes for the 1 minute color evaluation, for the 1 minute heart rate evaluation, muscle tone, and then there's that second code that's in the middle there is the score is the total score for the 1 minute post. So it's the sum of those original initial measurements. And then the other thing that you have is you have panel definitions. That, for instance, there's a panel definition that tells you that the 1 minute post-birth panel actually consists of those 5 top measurements. And so you have, in LOINC, we have all of the 1 minute measurements, all of the 5 minute measurements, all of the 10 minute measurements. We have the total scores for each of those individual things, and then we have panels that group those together so that you can easily grab all of the 1 minute APGARs or all of the 1 minute, 5 minute APGARs as a collection that's supported within the LOINC file itself. Another example is like the FLAC pain scale, just showing here that you have for the pain scale, you evaluate the face, legs, activity, cry, consolability of the and for each of those they get ranked 0 to 1, 0 to 2, and again in LOINC then you have pain severity face, pain severity legs. You have in the method that this is the FLAC methodology for collecting the pain scale. Then you have the total pain severity, and then again you have the FLAC pain assessment panel. So it puts all of those things from that assessment scale into one panel for easy consumption by people who are making applications. So that's all I'm going to say about assessment scales. But there's Brayton scale. There are a number of these that are part of the LOINC database. Now we're going to talk about survey instruments. So survey instruments, sort of the LOINC leader / expert on this has been Tom White, who's done a lot of work and really help form the conceptual framework by which we do this work. But Clem and Dan and Kathy and others at Regan Street, I think, have done all the heavy lifting to really make these things work. But the idea is, and this comes back now to what you were talking about and asking about, is that you have these kind of questionnaires. In this case, I'm showing an example of the minimum data set. You have these things that have traditionally been done as a paper form. We now want to make them electronic forms, but we also want to be able, however it was collected, be able to transmit the data from that form electronically and have LOINC codes for them. And so these are a special kind of thing within LOINC. And you have basically recreate each of the data elements, and each item, each data element that can be entered into this form becomes a unique LOINC code, and it also has, if it's something that has a particular answer list associated with it, it also has the answer list, a computable answer list that's associated with that question. And Clem might show some of this when he gets in and does RELMA. This is just a screenshot from RELMA that is showing the MDS assessment form, and you have the copyright notice. You have some of the basic properties about the class of this thing, but then you start seeing the individual LOINC questions that are associated with this item. And when we get into RELMA, we can look at some of these, and you can see how the association is made between the question and the specific answer list for that question. The unique code for that answer list is used within the questionnaire, and then those things all become actually LOINC parts that are individually identifiable within the LOINC database. So that's what we've shown now. Basically, is that the difference sort of between a panel and these survey instruments. The panels are made up of, if you will, sort of the standard. A standard set of LOINC codes, and a survey instrument really allows you to specify the order of things, and allow you to specify the exact answer list for the question, as well as maintain the exact wording of the question. And so those are special attributes that apply to survey questions, whereas typically with standard LOINC codes, you're not worried about the particular wording, you're just worried about the semantics that are being conveyed by that measurement. So I'll stop there and let you ask more questions if you want me.
You just said something that struck me. You said for a survey, you had the exact answers.
If the survey specifies, that the answers have to come from a particular list, then we can capture that in LOINC.
Wouldn't you have that as part of a panel? That's what I'm wondering.
Yes. You can do it with panels also. So, you can use, once we've created the underlying machinery, you can use it, in sort of either circumstance. And we're going to come back, Sundax submitted some questions, and we can go back and answer Sundax specific questions. But, the last thing I want to talk about is just about collection. We really realize that there are two kinds of things in LOINC that contain more than one item. There are things that contain individual measurements, like a Chem 7 panel, or with clinical LOINC, it would be like vital signs, where you have a well-defined thing that, you say vital signs contains a blood pressure, a heart rate, a respiratory rate, a temperature, etc. Where you have defined content that is referring to other LOINC codes. But then you have other things that are less specific, where you just say, this is a bone marrow exam, or this is an operative note, and you haven't specified all of the content that could be in that collection. And so there are questions about whether you can make orders versus,
collections for orders or results, whether medication history is a single paragraph, or you can put individual unique codes for each medication, and different kinds of things basically with panels or documents. So sort of the rules for these collections basically come down to this, that for individual measurements, we make codes that distinguish between character identifiers, strings, codes, dates, and numbers. But we can create generic parents as needed to relate parents and children into hierarchies, and we're gonna talk about the hierarchies again with I think that's maybe tomorrow when we talk about hierarchies. But for collections, we distinguish panels from documents. So we recognize that both of those things are collections of things. But a panel is something that basically its contents are defined by reference to other LOINC codes. And a document is a collection that is less general and doesn't have a very specific definition yet. And so we could basically make a specific operative note panel. If we made it a panel, it would imply that we had defined the exact set of other LOINC codes that would be contained in that document. If we made it a general document, it would imply that it should contain an operative note, but we haven't said specifically what the sections needed to be or other specific LOINC codes that would need to be contained in that item. So that's sort of it's maybe a little bit arcane, but it's turned out to be a very important distinction between panels that are essentially the distinction between things that are well-defined and computable and things that have a good deal of variability in the content that you expect there. So, and then the final thing is just that we, again, use the same codes for results as we do for orders. So you can use panels in orders, you can use panels in results as the OBR, and you can use individual codes. That you would use the same code to order a hematocrit as you use to represent that an OBX contains the actual measurement of the hematocrit. So other than a literature reference, that's my last slide. So I'm over time.
One last question, Stan.
Yes.
Where do you have all this written down?
This is most of it is written in the reference manual that's distributed with the LOINC distribution.
Right.
I say most because I couldn't guarantee every piece of this is written down. Probably everything that I've said here, we have at least a document that describes that, and I can send those documents to you if you're interested.
And you make available a copy of your presentation?
Yeah, I'll be glad to send anybody a copy of this slide set, and I can put it on a thumb drive here for anybody who wants one here.
And would you want us to just send you an email if we're interested in it?
Yeah, just...
Stan, can you put in the LOINC website, because it will be more useful so that we can refer to the LOINC website rather than just forwarding the email.
Hard to get through to work with.
Yeah, I can believe that. But I mean, if anytime you do have that, I mean, if you have specific suggestions about ways we could make it better, we would be glad for that criticism as well. So I apologize for being overtime. We'll come back. So let's take a break for 15 minutes. So we'll start up again at 10:30 Mountain Time. So 15 minutes from now, and we'll start up with questions, and then with Plum giving us a guided tour of Realm. What's that? It's on live meeting. You can, if you're connected to the network, you can go into live meeting or